Hi, hello everyone. I'm Kavindra Rajendra. I'm from OUM Alosta Learning Center. As a requirement for clinical practice trauma and emergency care, we need to do clinical posting at assigned government hospital to fulfill the particular hours needed apart from our own clinical area. I was assigned to emergency and trauma department of Hospital Pulau Pinang. As a part of our task, a case study needs to be submitted along with the case presentation. I preferably present a case study of I preferably present a case study of polytrauma patient care, primary survey and management in emergency in emergency hospital Pulau Pinang. As everyone knows, according to the most current information from the World Health Organization and Center of Disease Control, more than 9 people die every minute from injuries or violence, and 5.8 million people of all ages and economic groups die every year from unintentional injuries and violence. Motor vehicles crashes alone cause more 1 million deaths annually and estimated 20 million to 50 million significant injuries. Polytrauma is a clinical syndrome where a patient sustains serious injuries involving two or more body systems or any vital. Polytrauma injuries can lead to impairments in physical, cognitive, psychological, or psychosocial functioning. Common injury mechanisms include crashes involving motor vehicles, bicycles, and other vehicles. According to the public safety statistic reported by Royal Police Malaysia, road traffic accidents was among the 10 principal medically certified causes of death in 2018 in Malaysia, with ranking number 4. Immediate and early trauma deaths are generally due to primary traumatic brain injury, acute blood loss, and hemorrhagic shock. Emergency department care of polytrauma patients is a crucial aspect of optimized care and premature death prevention. Polytrauma is a life-threatening entity that requires immediate action by all specific involved. Upon arrival to emergency department, the patient will be seen and assigned by all and specific medical personnel such as radiologist, surgeon, emergency physician. Within the first minute to hours of managing polytrauma will consist of several steps such as primary survey, secondary survey, resuscitation, stabilization, and also the definitive care. The basic principle in emergency department on managing trauma patient are golden hours rules. Golden hour are the first hours are characteristic by rapid transportation, rapid assessment and stabilization, rapid definitive care. In our nation, most hospital guideline follows current advanced trauma life support 10th edition. Same goes to the practical place that I went, emergency and trauma department of hospital. Management consists of a rapid primary survey with simultaneous resuscitation of vital functions, a more detailed secondary survey, and initiation of definitive care. During the primary survey, life-threatening conditions are identified and treated in a prioritized sequence based on the patient injury. The primary survey encompasses the A, B, C, D, E of trauma care and identify the life-threatening condition accordingly. First of all, A is the airway maintenance with cervical spine motion. B comes with breathing and ventilation. C comes with circulation and hemorrhagic control. D, disability. And E is exposure and environmental control. Okay, let's move on to case scenario. as I working on PM shift on the 19th, uh, 19th November 2020, I've went for an ambulance call with emergency department team, which we received an emergency call from public claim that patient had alleged MVA road traffic accident, stating that motorbike rider versus a van at Jalan Payaturbo. History from the caller, no eyewitness. How does the mechanism of injuries happen? Upon arrival to the scene, a 28 years old male with no past medical history, unremarkable family history, unmarried, working as a waiter. He's an active smoker. Patient unsure of any substance induced. Upon arrival, patient claimed that he having shortness of breath, pain over the right side of chest wall, and also patient having pain and presented with obvious deformity over the left lower limb. The patient was still intact with helmet with a broken shield. Primary survey and initial management were done at scene, and the estimated time arrival to hospital was took for 20 minutes. So upon arrival to hospital Pulau Pinang, we traced the patient to red zone. At red zone, I attend the patient together with my emergency physician, nurses, and other working mates. At red zone, a quick primary survey done with the trauma team. Patient was initially respond to the pain. Patient airway was patent, patient able to talk when we asking a question, patient spine was protected, patient was intact with cervical collar and head immobilizer. Patient was brought in by ambulance crew with high flow mass oxygen 50 liters per minute. Patient also was inserted two large bore cannula over the left bilateral left cubital fossa with 1 liter fluid were given in ambulance. During the assessment, patient complaining shortness of breath and patient is getting more tachypneic with respiration rate 38 per minute. Patient difficult to complete the speech with mild bruises over the right side of chest wall. Patient also presented with distended neck vein, asymmetrical chest rise, tracheal partially deviated to the left side. On the examination of chest spring, positive over the right side of on our palpation, hyperresonate, note on percussion over the right side of the chest with reduced air entry on auscultation. The sign shows patient is having tension pneumothorax. So we started to perform a needle thoracocentesis. A needle size 8 cm were used to perform needle decompression. Needle catheter was inserted at fifth interspace, slightly anterior to the mid-axillary line. Tension pneumothorax was released with a gush sound, and patient oxygen saturation level has improved. Patient, our further assessment was moved on to patient circulation and hemorrhagic control. Patient CRT was less than 2 seconds, but patient peripheries was cold, patient having a poor pulse volume. So we were suspecting patient is having some sort of massive bleeding. So on our examination, we noted patient was intact with left lower limb was intact with splint with compression bandage over the open wound over the left thigh. Patient already intact with intravenous access, two large bore cannula over the antecubital region. So patient is having massively bleeding over the left thigh, mid shaft of femur. So patient already applied with splint and compressing bandage. So we continue our inspection, palpation, percussion, auscultation assessment to patient abdomen. There is no wound over the abdomen region. There is no any bruises. There is no any abrasion wound, laceration, or penetrating wound over the abdomen region. On 9.9 point of palpation, no any tenderness, no any guarding. Patient abdomen was soft. So we further our assessment to patient pelvic. Patient pelvic spring was negative on our palpation. There was an then we take patient's vital sign. Noted patient BP was 90/60, pulse rate was 120 beat per minute, oxygen saturation was 96% under high flow mask, respiration rate was 38, patient blood sugar level was 4.3, temperature was 35.8, patient GCS which is initial in pre-hospital care was 12/15, and patient GCS gets 10/15 E3 V5 M2. When we exposed patient with patient privacy, presented with multiple abrasion wound with the facial or the thorax region, upper limb and lower limb. Patient also presented with deep laceration wound over the scalp and also the mandible region. No crepitals felt on the facial bone. So we resume our primary survey, adjunct to primary survey. So chest x-ray was ordered, and there's the result of the chest x-ray was mediastinal shifts towards the left side of lung, depression of the hemidiaphragm. So we can really sure that was a tension pneumothorax, and we're going to proceed with chest tube insertion. Patient pelvic spring pelvic x-ray was clear, no any fractures seen. Fast scan was done, no any free fluid seen. Patient atrial blood gas was taken, pH noted 7.18, and the atrial blood gases was taken, and patient pH level was 7.18. Patient PCO2 was 55, and patient bicarb was 24. So patient is having metabolic acidosis. Secondary assessment was continued. Full blood count was taken, and noted patient HB was 9.3. A total white blood cell was 23, and our provisional diagnosis was polytrauma sustained with right-sided lung tension pneumothorax, class 3 hemorrhage shock, open fracture over the mid shaft of femur, cerebral concussion. So trauma is a leading cause in all over the place, especially death in America has increasing year by year due to this traumatic injury. Traumatic injury can range from minor isolated wound to complex injury, which is multiple organ system, as we've seen in this patient. So to prevent from death, we should start an initial and faster treatment for the patient. Airway management is the one of the most important skill for emergency department to master, because failure to secure the adequate airway can quickly lead to death or disability. So endotracheal intubation was done for this patient using rapid sequence intubation in in the decision to intubate is sometimes difficult, but the reason why we intubate this patient for the airway protection. There are 5 indications for endotracheal intubation. First of all, inability to maintain airway patency, inability to protect the airway against aspiration, failure to ventilate, failure to oxygenate, anticipate of deteriorating cause that will eventually lead to respiratory failure. So this patient was intubated for cerebral protection and airway compromise. So before we intubate the patient, we must make sure we have to follow the mnemonic 7P. To intubate a trauma patient, C-spine protection is very important. The cervical collar may be removed with dedicated assistant providing inline immobilization. Removing the anterior part of cervical collar while maintaining inline cervical spine immobilization is acceptable and may cause less cervical spine movement than cervical collar immobilization during laryngoscope for endotracheal intubation. In the setting of COVID-19 pandemic, it's important that tracheal intubation be performed in adherence with recommendation from national and international organization. Endotracheal intubation can be aerosol generating procedure. Emergency medicine clinical should practice of wearing full protection, full PPE during this procedure. So what are the 7 P's that we need to prepare before intubating a patient? First, we need to preparation. What preparation? We have to follow the Mills law plus 4S. First M is mask and monitoring. For example, non-rebreather mask, cardiac monitor, all the vital sign monitor. The airway adjuncts, oropharyngeal airway, nasopharyngeal airway, and difficult airway trolley. L stands for laryngoscope, blade size, Macintosh for adult, handle with attached blade, make sure the lights all is functioning. ET tube, we use 7.5, which is suitable for adult. Functioning suction machine, stylet, which is placed into the ET tube. Stethoscope to assess patient, to auscultate the patient after intubation. Syringe and securing tape. So make sure we have all our equipments before we intubate our patient. So pre-oxygen, established of oxygen reservoir within the lung, blood and body tissue to permit several minutes of apnea without arterial oxygen desaturation. Administration of 100% oxygen for 3 minutes was done. Then administration of pre-medication, administration of drugs to mitigate adverse effect associated with intubation. So given 3 minutes before induction agent, IV fentanyl was given 1 mcg per kg over 30 to 60 seconds. After we given fentanyl, paralysis with induction were given. Administration of rapidly acting induction agent, dose adequate to produce prompt unconscious immediately. So we use midazolam with dosing of 0.1 to 0.5 mg per kg. So the advantage of using midazolam is a sedative, and the disadvantage is hypotension and respiratory suppression. So while we giving midazolam, we have to make sure our cardiac monitor, our vital sign monitor are well attached to the patient, and we have to concentrate on their vital sign. And after given paralysis, we have to give neuromuscular blocking agent. So rocuronium were used as non-depolarizing muscle relaxant. Of the dosage, 0.6 to 1.2 kg, 1.2 mg per kg was given and observed for fasciculation. After fasciculation has observed, we has open patient airway with proper manual inline. No any dentures was intact. Positioning patient, placement of ET tube was done. Placement with proof during laryngoscope is performed with visual the glottis. Endotracheal tube is passed in between the vocal cords and the cuff inflated around the tube to hold in place and prevent aspiration to the stomach. So how we prove that ET tube has inserted to the vocal cord? By direct visualization from the end-tidal CO2 detector, vapor inside the endotracheal tube, SpO2 monitoring, and 6 point of auscultation. And our first point of auscultation should be the stomach. Post-intubation care, as we all know, what are the post-intubation care? Such as Ralph's tube insertion, catheter drainage, bladder drainage insertion. ECG was performed to identify any abnormalities in cardiac electrical activity. Chest X-ray was done, and endotracheal tube placement was confirmed. Upon patient airway was protected, tube thoracostomy is inserted for the patient if pneumothorax is under tension. Then following needle aspiration, the insertion of chest tube will be necessary. So we already inserted our needle decompression initially after we diagnose patient is having tension pneumothorax. Then we protect patient airway with performing endotracheal intubation. Then we perform with insertion of chest tube for this patient. The location of inserting chest tube is include the fourth, fifth, or sixth intercostal space in the anterior axillary line. The nipple is landmark for the fourth intercostal space. After inserted the chest tube, vital signs were repeated. Ausculted bilateral lungs, portable chest radiography was ordered for verified lung expansion and placement of chest tube. Finally, we continue our assessment. Look for any continuous sign for any air leak being evacuated. Common complication that happens due to chest tube are persistent pneumothorax, subcutaneous emphysema, injury to the diaphragm, and infection. Then we carry on with the medication that we should administer for this patient. For example, we cover with broad spectrum antibiotics, IV metronidazole 500 mg, cefuroxime 1500 mg, fluid resuscitation and blood products. Since patient is having class 3 hemorrhagic shock, we given ambulance team has given 1 liter of normal saline. So activation massive transfusion protocol, 1 liter of mass activation of massive transfusion protocol. The normal saline follows with packed cell 2 pints. Full length compression bandage to stabilize the fracture after irrigation over the wound done. Close monitoring of the patient, especially for hypotensive episode and tachycardia for every 10 to 50 minutes. CT abdomen once patient hemodynamically stable, unlikely for operative management. Close external fixation over the left femur. Decision was made by our orthopedic team. After completing all our documentation, patient has stabilized, patient vital signs stable, chest tube placement was confirmed in place with presented with air leak over the underwater seal. All our documentation was done proper. Patient was sent to intensive care unit. So what I have learned from this case study is tension pneumothorax develops when one-way valve air leaks occurs from the lung or the through chest wall. Air is forced into the pleural space with no mean space, eventually collapsing the affected lungs. The mediastinum is displaced to the opposite side, decreasing the venous return and compressing the opposite lung. Obstructive shock results from marked decrease in venous rhythm, causing reduction in cardiac output. The most common cause of tension pneumothorax is mechanical positive pressure ventilation in patient with visceral pleural injury, chest pain, air hunger, hypotension, respiratory distress, hyperresonant note on percussion, defected trachea, distended neck vein, and absent breath sound are a sign of tension pneumothorax. For this patient, we have successfully done needle decompression, which convert the tension pneumothorax to a simple pneumothorax. Tube thoracotomy has also done, which is a mandatory after needle decompression of the chest. So another thing that we learn is the first step in managing shock in trauma patient is recognize the presence. Once shock is identified, initiate treatment based on the probable cause. Shock is an abnormality of circulatory system that results in inadequate organ perfusion and tissue oxygenation. Hemorrhage is the most common cause of shock in trauma patient. The trauma patient responds to blood loss is made more complex by fluid shifts among the fluid compartments in the body, particularly in the extracellular fluid compartment. The response to blood loss must be considered in the context of this fluid shift. So this patient was having class 3 hemorrhagic, typically presented with classic sign inadequate of perfusion. Patient was having including marked tachycardia, tachypnea, significant changes in mental status, and patient measurable fall in systolic patient blood pressure. So in conclusion, guys, the initial rapid assessment and immediate resuscitation of polytrauma patient in emergency department in hospital setting is crucial to as the first golden hours can be implied as most primary teams and specialists to proceed with definitive care and referred for further management are readily available. So as a team in a trauma team, we have to contribute our perfect work while resuscitating a patient. We should not have any egos, misunderstanding with our trauma team. We have to listen to our team leader who assigned the job. We have to be clear on our job and we have to keep a close loop communication with our teammates. Trauma setting is very different settings compared to every other place. So while managing a polytrauma patient, we need passionate towards our career. So before I end my video, I would like to thank OUM for giving this opportunity for us to continue our practice in emergency care. And my huge thanks to Encik Norhan who encouraged us and guide us to perform this video, this assignment and perform well in our studies. Thank you very much. Hope you enjoyed my video.